Hello dear students, welcome to yet another session of pediatrics. I hope these pediatric sessions are helping you with your studies and stimulating you to read more. Continuing with neonatology, in the second part we are today going to discuss various problems faced by a premature infant or a premature newborn and a little bit about neonatal hyperbilirubinemia and hemolytic disease of newborn. Prematurity. When a newborn is delivered before 37 weeks of age, it is labeled as a preterm or a premature newborn. The usual term gestation lasts from 37 to 40 weeks. So a delivery that is happening between 37 to 40 weeks is called as normal labor or a full term normal labor. There are various challenges faced by a premature newborn. Because it is coming out of the mother's womb early, so many of the organs are immature. For example, his lungs, they are not producing enough of surfactant. The gut is not yet capable of handling the feeds. The brain is not mature. The brainstem function, the control of the respiration is also not mature. And various blood vessels in various layers of the brain, they are also immature and very fragile and liable for rupture. The maximum weight gain that happens is during the third trimester. At 28 weeks of gestation, a fetus weighs somewhere around 1 kilograms, and at term they are almost 2.5 to 3 kilograms. So this rapid weight gain happens in the third trimester. So you can imagine if a baby is delivering preterm, it is naturally going to be a low birth weight baby. Maximum accretion of the nutrients, for example calcium, glucose, maximum gluconeogenesis happening in the liver and build-up of the glycogen in the liver happens during the third trimester. So if in preterms the liver stores of the glucose are less, the calcium accretion is also less. Low birth weight is an independent risk factor, and I would like to draw your attention here. Low birth weight merely means that the birth weight of the newborn baby is less than 2.5 kilograms or less than 2500 grams. Let me remind you that all low birth weight babies need not be preterm. For example, if a baby is delivering at 37 weeks and has a risk factor such as pregnancy induced hypertension, he may be low birth weight at birth. He may be weighing less than 2.5, but he is a full term baby. So low birth weight merely gives us an idea about the weight at birth irrespective of the gestation. There are various definitions of low birth weight. Depending on the gestation, if the birth weight at a given gestation, if it falls below the 10th percentile, then it is called as low birth weight. There are two concepts in low birth weight: appropriate for gestational age and small for gestational age. A baby who is appropriate for gestational age falls between the 10th percentile to the 90th percentile for the gestational age, and if he falls below the 10th percentile, then it is labeled as small for gestational age. IUGR or intrauterine growth retardation is an ultrasound diagnosis. So till the baby is inside the uterus and there is an evidence of growth retardation, we label it as IUGR, but soon after the baby is born, the baby is delivered, IUGR, this terminology will be replaced by SGA or small for gestational age. There are two varieties of SGA babies. One is symmetric SGA and another is asymmetric SGA. If the insult or the deprivation, the nutritional deprivation occurs much earlier in the intrauterine course, then the growth of the brain as well as the bones will get hampered. So naturally these babies will be born symmetrically small. So they will shrink in size such that their head size, their torso and their length and weight, everything is reduced proportionately. So these are symmetric SGA. And if the insult or the deprivation occurs late in the pregnancy, in the later course, their length is usually spared, the head circumference or the brain growth is usually spared, but what is getting hampered the most is the weight of the baby. So these are called as asymmetric SGAs. Ponderal index is something similar to your body mass index. So BMI is a measure of the leanness or the thinness or the thickness of the individual. Similarly, ponderal index is an index which gives us an idea about the thinness of the newborns. So the formula is in front of you: weight in grams divided by the cube of length in centimeters, everything multiplied by 100. And the values that we get in symmetric SGA are usually less than 2. In appropriate for gestational age as well as symmetric SGA babies, the ponderal index is above 2. So how do we differentiate between symmetric SGA and an appropriate gestational age? Because both of them have a ponderal index above 2. So we have to plot the weight on gestation specific growth charts. If the weight is falling below 10th percentile, it is an symmetric SGA. If it is above 10th percentile, then it is appropriate for gestational age. Various risk factors for prematurity and low birth weight. These risk factors are common generally for both these conditions. Maternal conditions such as systemic disorders in the mother, like underlying chronic diabetes or any congenital heart disease, any abnormalities of the uterus. If the uterus is bicornuate or unicornuate uterus, when it doesn't have enough space to expand, or if the os or the internal os, or if the cervix is incompetent, certain infections like listeria and group B streptococci can also give rise to preterm delivery. Placental factors like PIH, placenta previa and abruption also give rise to prematurity. Multiple gestations is a common cause of preterm babies. Usually the twins are delivered preterm. And there are certain external factors such as trauma or premature rupture of membranes due to any reason can also give rise to preterm delivery. Coming to various problems faced by a preterm baby, the most common problem that is encountered is hyaline membrane disease or respiratory distress syndrome. Intrauterine growth of the lungs is a continuous process, and the surfactant production usually starts at around 20 weeks, but it reaches the maximum levels, that is the mature levels, at around 35 weeks of age. So the babies born beyond 35 weeks of age usually do not develop respiratory distress syndrome. There are various mechanical and physiological changes happening at the first breath. As the baby is passing through the vagina, the chest gets compressed and the fluid that is accumulated in the lungs, it gets emptied. The placenta is getting constricted, so the placental blood flow is also less. This stimulates the brain of the child because of hypoxia, hypercapnia, and finally reduced pH of the blood. So these are the stimulating factors for the first breath. And as the mature respiratory center gets stimulated, the baby takes the first breath. Soon after the first breath, some of the alveoli open, and after this inspiration, the baby cries against a closed glottis, generating a positive pressure, and this positive pressure opens up the rest of the alveoli and creating a functional residual capacity. So FRC is generated by this crying against the closed glottis. So this is the importance of cry at birth, and surfactant plays an important role in keeping these alveoli open. Surfactant is a surface tension reducing agent. It is secreted by the type 2 alveolar cells, and what it does is it helps the alveoli remain open even at the end of expiration. So when the alveoli are remaining open even at the end of expiration, it helps in the gaseous exchange. So coming to respiratory distress syndrome, the very fact that the surfactant is not getting produced leads to this respiratory distress syndrome. Because there is atelectasis of the smaller alveoli, they are not remaining open, so they get closed at the end of expiration, and this leads to lack of gaseous exchange, leading to the manifestations. So prematurity is the most important risk factor, and other risk factors are diabetes in the mother, hypoxia, acidosis, and hypotension are further aggravators of the surfactant deficiency. The clinical features are respiratory distress soon after birth, ideally within minutes of birth, but sometimes it can present up to 6 hours from the birth. They can get tachypnea, lower chest retractions, cyanosis. So this picture is very much similar to any respiratory distress like in congenital pneumonias or even meconium aspiration syndrome. But the key feature here is, first, there is history of prematurity and the lung volume is usually less. If we compare a radiograph of respiratory distress syndrome versus meconium aspiration syndrome, what we would appreciate is in RDS, the lung volume is low because of the atelectasis. Atelectasis is the volume loss, so the chest diameter is less. The signs of respiratory distress build over next 3 days, and usually it is, in most cases, gradual recovery happens after 3 days. In severe cases, the child may develop hypotension, severe cyanosis and apnea. Chest X-ray, other than showing low volume lungs, also reveals a reticulogranular pattern, and in severe cases we can get bilateral whiteout lungs. Blood gas reveals hypoxemia in early stages. In later stages there is a build-up of carbon dioxide and metabolic acidosis. Treatment is supportive. Most of the cases are managed by giving positive pressure ventilation, either by a non-invasive method such as nasal prongs or an invasive method such as endotracheal intubation and positive pressure ventilation. Surfactant is the drug of choice, and it is to be given in 2 to 4 doses through the endotracheal tube. The common side effects of surfactant are hypotension, apnea, obstruction of the endotracheal tube, and sometimes, or due to rapid fall in the resistance, and as the lungs become more and more compliant, they are likely to get ruptured and thus leading to pulmonary leaks. The ventilatory strategy used is high rates and small tidal volume to prevent volume trauma and barotrauma to the lungs. We have already discussed complications like apnea and pneumothorax. The long-term complications of PDA are bronchopulmonary dysplasia, where the lungs are oxygen dependent, and there is also toxicity because of this oxygen, and this gives rise to bronchopulmonary dysplasia. Pulmonary hypertension and cor pulmonale are some of the long-term complications. What can we do to prevent development of HMD? First and foremost is preventing premature labor. So managing all high-risk pregnancies is the key factor, and if the lady goes into preterm labor and the delivery is imminent and it is most likely to happen within next 24 to 48 hours, then we induce the pulmonary maturation by giving steroids to the mother. So there are 2 drugs preferred, betamethasone and dexamethasone, and the dose schedule is 12 milligrams of betamethasone every 24 hours, and we need to give 2 doses. Coming to necrotizing enterocolitis, NEC or necrotizing enterocolitis is another life-threatening condition in newborn babies, especially in preterm newborn babies. The risk factors are prematurity, as we have already discussed, and more importantly, if the feeds are started very rapidly, or if there is underlying injury to the mucosa with superadded infection. So these are the risk factors for developing NEC. The clinical features in NEC are predominantly gastrointestinal in the form of feed intolerance. The child who was initially tolerating 4, 5, 6 ml of milk is now not tolerating, and before giving the next feed, everything is coming out of the nasogastric tube. So that is the earliest sign of NEC, followed by abdominal distension, vomiting, discoloration around the umbilicus are some of the gastrointestinal symptoms. Non-gastrointestinal symptoms are shock, hypotension, apnea, poor perfusion, lethargy, and glucose instability. The diagnosis of NEC is to be made clinically and on laboratory parameters. An erect X-ray abdomen will reveal pneumatosis intestinalis. Pneumatosis intestinalis is the presence of air or the air bubbles in the bowel wall. So it is the earliest sign of NEC on X-ray. We can also get multiple air fluid levels because of the paralytic ileus. If the bowel perforates, it will give rise to a gas under the diaphragm. In late or severe cases, we can also get gas in the portal vein. The typical laboratory triad of NEC is hyponatremia, thrombocytopenia, and metabolic acidosis. This is a typical multiple choice question asked in many of the exams, and all these 3 parameters on a visual impression do not go in hand with your NEC, because none of these are the parameters of gastrointestinal symptoms, gastrointestinal system. So please remember thrombocytopenia, hyponatremia and metabolic acidosis. The treatment again is symptomatic and supportive. The first step is to withhold the nasogastric feeding, so keeping the child nil by mouth, emptying the gastric contents and deflating the intestines, monitoring for underlying acidosis and electrolyte abnormalities and correcting if they are present. The role of exploratory laparotomy or the surgery is limited if there is associated perforation. Infant of diabetic mother. Now we have completed the preterm and now we are moving to complications in large for gestational age babies or LGA baby. So what is an LGA baby? If the birth weight is more than 90th percentile for the gestation. Infant of diabetic mother is the commonest cause for LGA. The pathophysiology behind LGA or the macrosomia in infant of diabetic mother is the mother is having high blood sugars. So transplacentally the baby also gets elevated blood sugars. So the natural reaction to this elevated blood sugar is the pancreas of the fetus starts producing more and more insulin. And as we know, insulin is an anabolic hormone, so it gives rise to tissue growth. It gives rise to lipogenesis, glycogenesis and macrosomia. It also stimulates protein synthesis and increases hepatic glycogen stores. Macrosomia is not universal in infant of diabetic mothers because if the diabetes is long-standing and the mother has already developed vascular complications, these are the pregnancies where diabetes can give rise to IUGR and not macrosomia. There is a subtle difference between IDM and infant of mother with gestational diabetes. Gestational diabetes is an entity which develops during the pregnancy, and infant of diabetic mother, where we have a diabetic mother who is now conceiving. Gestational diabetes is the babies of gestational diabetic mothers are also macrosomic at birth. Clinical examination reveals a macrosomic baby with a plethora. They are usually puffy and they are jittery or jumpy. When we hold the baby, they shake and they shiver. The pinna is often hairy and they are at a high risk of developing various congenital malformations. Congenital malformations are not seen in gestational diabetics, but they are seen in infants of diabetic mother. Cardiac complications are ASD, ventricular septal defect, TGA, truncus tricuspid atresia, and more commonly asymmetric septal hypertrophy. Lumbosacral agenesis is less common but is a specific malformation seen in infants of diabetic mother. Soon after these babies are delivered, they are at a high risk of developing hypoglycemia because there is a sudden cutoff in the glucose transfer across the placenta, and the insulin levels, the basal insulin levels are very high. So they are at a high risk of developing hypoglycemia, usually within first 1 to 3 hours of life, and it's as soon as the feeding is initiated, the hypoglycemia reverts back. They are also at a high risk of developing hypocalcemia, hypomagnesemia, because diabetic mothers, they lose magnesium through their urines, and there is a partial parathyroid hormone resistance. So this is the underlying mechanism for developing hypocalcemia. And because of the high RBC content, they are also at a high risk of developing jaundice. So hyperbilirubinemia is another derangement. Because of their macrosomia, often they are at a high risk of developing shoulder dystocia and various birth injuries such as fractures of the long bones. They are commonly seen in macrosomic babies. Management of IDM is mainly focused on the initiation of feeding, early initiation and regular feeding. The blood sugars need to be monitored frequently over initial few hours of life, and we also need to monitor the hematocrit and bilirubins. The hypoglycemia needs to be treated with a bolus if it is a symptomatic hypoglycemia, but if the hypoglycemia is asymptomatic, the first step needed is to give feeds urgently and repeat the sugars. Surgical emergencies in newborn. I will be discussing 4 or 5 surgical emergencies. First of the emergencies is esophageal atresia. These children, please recall the routine newborn care where we have already discussed we rule out certain conditions by putting a nasogastric feeding tube through the nose. So we rule out the choanal atresia and we also rule out the esophageal atresia. So if the esophageal atresia is present, the nasogastric feed will not go inside and we will not get the positive air sufflation test. These children present with frothing at mouth soon after the feeding, and many of the times they also develop aspiration pneumonias. Diaphragmatic hernia is a life-threatening surgical condition, but the Bogdale's hernia or the posterolateral hernia is the most common variety. Many of these are associated with underlying pulmonary hypoplasia. Because the intestinal loops are present in the chest, they prevent the development of the lungs on the unilateral side. They have a scaphoid abdomen and increased AP diameter of the chest, and we can hear the gurgling sounds on the auscultation. Remember, bag and mask ventilation is the first reflex when we see a child who is not breathing, but congenital diaphragmatic hernia is the contraindication for bag and mask ventilation because we are going to aggravate the problem. After doing the bag and mask, some of the air invariably goes into the esophagus and the stomach, and since the stomach and the intestinal contents are herniated in the chest, they will be air filled and further they will compromise the ventilation. So these babies, if they develop apnea or they need to be given positive pressure ventilation, endotracheal intubation is the first step and not a bag and mask. Imperforate anus is many of the times associated with esophageal atresia, and these children need urgent colostomy. Hemolytic disease in newborns. As we know, hemolysis occurring in a newborn baby, it can start antenatally or after birth. The underlying pathology is the maternal derived antibodies that are destroying the fetal RBCs and causing hemolytic anemia in the fetus or the newborns. There are two major varieties. First is Rh isoimmunization. It occurs in Rh negative mother with previous exposure to Rh antigen, and ABO incompatibility. It occurs usually in mothers with blood group O, and if the fetus is having blood group of A or B. Hemolytic disease of newborns is a common cause for hydrops fetalis, and the favorite multiple choice question asked about hydrops fetalis is, following are the causes of hydrops fetalis except, and you can get various combinations of alpha thalassemia, you can get congenital nephrotic syndrome, congenital heart diseases. So a multiple choice question can be formed in multiple ways on hydrops fetalis. So this is a key point. Coming to Rh isoimmunization, it occurs in an Rh negative mother with Rh positive baby. There needs to be a sensitization where the mother is now mounting immunological response against the Rh antigen. Rh antigen is not naturally occurring antigen like A or B blood groups. So the mother needs to be sensitized either because of a faulty transfusion, if she had received Rh positive blood by mistake, or if there is a feto-maternal bleeding. So if the Rh positive fetal cells have entered the maternal circulation, it will sensitize the mother. The first response is development of IgM antibody, and as we know, IgM is a big molecule, it cannot cross the placenta. So usually the first baby is spared because it is protected. But what happens is subsequently this IgM antibodies will be replaced by IgG antibodies, and IgG antibodies can cross placenta, enter the fetal circulation and destroy the fetal red blood cells. So the chances of developing HDN increase with subsequent pregnancies. The clinical features depend on the degree of hemolysis. They can have mild anemia, early jaundice, or in severest form they can have severe anemia, compensatory hepatosplenomegaly, and also congestive cardiac failure because of the anemia. Antenatally, one can suspect HDN if we have a pericardial effusion, a halo sign, or a double bowel shadow on ultrasound. When we have a setting of HDN, we can monitor the maternal antibody titers. If they are above 1:16, then it predicts development of HDN, and if they are beyond 1:64, then it signifies a significant amount of hemolysis. Percutaneous umbilical blood sampling is the investigation as well as the management of hydrops fetalis, where we catheterize the umbilical vein of the fetus. We collect fetal blood for testing, and if it is below 5 or if there is evidence of severe anemia, we can transfuse the fetus with matched RBCs, and this fetal therapy is often repeated every 3 to 4 weeks until the maturity is achieved and the baby delivers.